Okay, so in this video we're going to go over chronic diarrhea, specifically involving children. So what we'll begin with is a quick definition of chronic diarrhea. So the definition for chronic diarrhea, if you're talking about infants and toddlers, the definition is going to be based on their weight. So this is when they have 10 grams per kilogram per day. And when we're talking about, I guess, older children, then we have just a general figure of if it's being greater than 200 grams per day. And this needs to persist for about 14 days, so 2 weeks of this, and we begin to consider this chronic diarrhea rather than acute diarrhea. What is this? I mean, obviously, it's going to be tough to measure this. So usually the other way it's described is if they have loose, watery stools more than 3 times per day. So this is a very loose definition of chronic diarrhea, but it's more practical in when you're eliciting history. So in this video, I just kind of want to go over the common causes and then kind of go over how to work up a patient that does have chronic diarrhea. So the first cause that we can go over is functional diarrhea. And this is not pathogenic or pathological. What happens is children are just having too much carbonated drinks, and it could be fruit juices, sodas, anything like that. So too many fruit juices or sodas can lead to it. And what's interesting about this one is this is only during the day, so only throughout the day, and it actually worsens throughout the day as they start to drink more and more of these drinks. It becomes worse. The other thing is there's going to be primarily painless. Obviously, there won't be any blood, and it will be no failure to thrive. So they won't be dehydrated or anything. They just keep having this symptomless or painless diarrhea throughout the entire day. So that's an interesting one there. You all definitely want to rule that out first, and it can be generally ruled out with history. So you just ask about a diet history, and you can figure that out. After this. One of the most common one is going to be is osmotic and secretory diarrhea. So this is a very common classification that's used, and it is helpful in figuring out in trying to categorize it in this way. So the first thing we talk about osmotic diarrhea. So osmotic diarrhea is when you have something that's non-absorbable in the gut, and so when there's a substance that cannot be absorbed in the gut, it becomes osmotically active, and when it becomes osmotically active, it starts to bring in the water from the intracellular enterocytes and bring it into the gut. So this is one effect. The other effect is because it's non-absorbable, it gets into the colon intact, and when it gets into the colon intact, that becomes food for the bacteria. And so the bacteria begin to take the food over, and it ends up producing organic acids. As it breaks down the food and it ferments the food, it produces this organic acid, and so you'll notice that the pH will be much lower, and it'll be watery as well. With regards to secretory diarrhea, this is slightly different. Here we have a toxin which activates either cyclic AMP or cyclic GMP. And when you activate cyclic AMP or cyclic GMP, this activates channels which causes water to rush from the cells into the lumen of the gut. And so then this will end up leading to secretory diarrhea. For cyclic AMP, let's talk about cyclic AMP. So cyclic AMP, the most common pathogens or the toxins that cause it is the cholera toxin, Labile toxin, which is secreted by E. coli, and the sugar-like toxin, and the sugar toxin, and the sugar-like toxin, which is secreted by Salmonella. With regards to cyclic GMP, this is primarily you're going to be looking at the heat stable toxin, which is also secreted by the E. coli toxin, and so that's cyclic GMP. So how do we tell them apart? There are certain laboratory and clinical features that do separate them, and so we can talk about them both one by one. So the first issue that separates them is secretory diarrhea tends to be much more they tend to have more than 200 milliliters per day, whereas with osmotic, there's less than 200 milliliters per day. And this is because in osmotic diarrhea, it's related to the food. So as much food as you eat, that's only the amount of fluid that's going to come out. Whereas in secretory diarrhea, the fluid is coming from the intestine, I guess you can say the enterocytes, and it just keeps on going as long as the toxin is active. So the secretory diarrhea is much more profuse. The second issue is the fasting response. So again, when we're talking about osmotic diarrhea, so let's put that there. So when you're talking about osmotic diarrhea, it's related to the food. So when the patient starts fasting, the diarrhea stops. Whereas with secretory diarrhea, since it's not related to the food and just a toxin, the diarrhea continues even with fasting. So fasting does not change the reaction of the patient to diarrhea. The reaction of the diarrhea to fasting. So the second thing that we can look for is reducing, whether in the stool there are reducing substances. Now, the only things that reduce is generally carbohydrates. So in osmotic diarrhea, a lot of times you're not absorbing carbohydrates. So in osmotic diarrhea, you will have reducing substances, whereas in secretory diarrhea, you won't. And continuing more, we already kind of alluded to the fact that in the osmotic diarrhea, the bacteria will take the carbohydrates and make organic acids out of them. So here the pH tends to be less than 5, whereas in secretory, the pH tends to be greater than 6. And finally, you can calculate something called the osmotic gap. The osmotic gap is determined by taking the sodium, adding up the sodium and potassium that's in the stool, multiplying it by 2, and then subtracting it from the serum osmolality. So what this will do is this will kind of give you a gap between the serum osmolality and the osmolality in the stool. So if the osmolality gap is greater than 125 milliosmoles per kilogram, we're looking at more osmotic, and if it's less than 50, okay, let's do this again. So if it's less than 50 milliosmoles per kilogram, then we're talking about secretory. So these are the very common ones that we deal with. And actually another set of conditions which can kind of fall into the secretory, besides the toxins, it can be a congenital cause. So any problems with where you have defect in any of the transport proteins in the gut, so any type of inherited defect will give you the same conditions, but they'll present much more chronic. So, and these can be defects in, like, say, sodium proton exchange. You can also have the chlorine bicarb. These are the two most common ones. The bicarb, chlorine, much more common. And so again, if the chloride pump doesn't pump chloride in, it stays out, and then you end up having the secretory diarrhea. Okay, so after this, we can go on to some of the other common causes, and such as the infectious causes. So generally, infections will clear up before 2 weeks, so they shouldn't occur longer than 2 weeks unless you get what's called a post-enteritis syndrome. Post-enteritis syndrome is the infection initially appears, so you get an infection and then it causes damage to the gut wall, so gut wall damage. And so the damage will take time to clear up, and so during that time the patient will have diarrhea, chronic diarrhea. There are some pathogens that can also cause chronic diarrhea. Primarily, there are some parasites. The most common parasite, especially in the young age, is going to be Giardia lamblia, which damages the gut wall, like we were talking about earlier in thing, and Entamoeba histolytica, which will cause the bloody diarrhea. After that, we've already talked about when we were talking about secretory, cholera toxin, labile toxin, stabile toxin, Shigella salmonella. So these are also other infectious causes that we've already covered. The other, I guess, category that we can talk about is immune causes. The first one can be immune deficiency. So immunodeficiency, of course, the first one we think of is HIV, but there also is IgA deficiency in children, chronic variable immunodeficiency, and many other ones that can occur. The other category is going to be autoimmune related, and one of these is celiac disease, which is becoming more common. Also ulcerative colitis and Crohn's disease, which is the inflammatory bowel conditions. There is also allergic enteropathy, and what this is they become allergic to a protein that they're eating, and then that protein it causes inflammatory reaction and it damages the cell wall. Most common is the cow milk protein, which is associated with it. The other one is going to be eosinophilic enteropathy. Here again, it's some sort of allergy to some substance, and this leads to an increase in dietary antigen, which raises IgE, and so that can lead to it as well. Finally, there is another category that we can talk about, which is called this is an important one, autoimmune enteropathy. In autoimmune enteropathy, this is associated with diabetes mellitus and the IPEX system, IPEX, I guess, syndrome. So in IPEX is an acronym for immunodeficiency or immune dysregulation. That's more accurate. They have polyendocrinopathy. You have enteropathy, and it's X-linked disease. So these are the general conditions that are related to the immune system. After these, what we can also look at is steatorrhea. Steatorrhea is when it's related to fat. So steatorrhea just means there's fat in the stools, and this is a very, very smelly type of stool. And there's two conditions which can lead to steatorrhea. First is going to be related to the pancreas, and the other one's going to be related to bile acids. Pancreas is required to absorb some of the food, so if you don't have the pancreas functional, you won't be able to absorb many of the foods and break down many of the foods that you eat, right? So the first condition can be is cystic fibrosis, which is the chloride transport. A genetic problem with the chloride transporter. There is also the familial chronic pancreatitis. This is due to a trypsin enzyme being resistant to degradation. And then there's three syndromes that are constantly mentioned. One is going to be the Shwachman-Diamond syndrome. There's also a Pearson syndrome. And then you have Johansson-Blizzard. Each one of these is, have many symptoms associated with it. One of them being pancreatitis. So we can mention all the symptoms, but it'll take a while, so you guys can look that up. But these three syndromes do have pancreatitis associated with it, and so one of the presenting features can be chronic diarrhea. So the other syndromes are so now we can, after talking about pancreatic causes, we can also talk about bile acids, causes that can lead to steatorrhea. And bile acids are important for absorbing fats. That's how fats get dissolved. And so if you don't have bile acids, you can't absorb any of the fats. And so you just have them, they can act osmotically, and they get passed through the stool, and you get this type of mucus in the stool. So what's one of the causes for bile acids will be chronic cholestasis, and anything related to the bile. The other thing can be is terminal ileal resection. This is commonly done in Crohn's disease, and the terminal ileum is responsible for reabsorbing bile. So if you can't reabsorb that bile, you tend to have a lower amount. The other thing is going to be bacterial overgrowth. So bacterial overgrowth, bacteria does deconjugate bile, and so that can lead to increased uptake as well. The other one is going to be patients who are taking the drug known as bile acid sequestrants. This is cholestyramine, and so the bile will not be uptaken again. And finally, there is a primary malabsorption of the bile where the actual transporter required for uptake in the bile is not there from a genetic perspective. Okay, so the other classes of conditions that can lead to chronic diarrhea is related to motility of the guts, and this can be caused in conditions such as diabetes mellitus. Malnutrition can cause this as well because the gut can't heal and so it's going to be weaker. Scleroderma, which is a muscle disease, and Hirschsprung's where the okay, so moving on, we can talk about now tumors which can cause it. There's three primary, and these are hormonal tumors, so you can put it under hormones or tumors, whichever you like. The first one is going to be gastrinomas. Gastrinoma is caused by Zollinger-Ellison syndrome, where you have increased gastrin, and this is going to increase the amount of gastric acid that's produced by the stomach. The other one is going to be VIP-oma. This leads to watery diarrhea and achlorhydria. And VIP is a hormone used to increase the secretions of the gut. So this can lead to chronic diarrhea. And the final category is going to be related to decreased surface area. So our final category is related to decreased surface area. This is classically short bowel syndrome. This is caused when there's necrosis of the gut, and which leads to surgery, and they take out too much gut, and it's no longer able to absorb everything. And celiac disease can also do that. It's an autoimmune condition against gluten, which causes the brush border intestinal villi to be flattened, and then so again it cannot absorb all the food, and then that food goes on to act like an osmotic diarrhea. So that's all the conditions, and there's a few of them there. Now, how would you evaluate a patient who does have chronic diarrhea? Well, the first step is taking accurate history. In the history, you want to first ask about the diarrhea, right? So the quantity, the color, if it's red, if it's mucus, what is it? Then you also want to talk about, so that's the characteristics. You also want to talk about how frequently it occurs, whether it's continuous, intermittent. You can also ask about the time of day, because of course if it's earlier in the day, that can be more towards the functional. You can also ask about whether it's associated with flatus, abdominal pain, and all those things. Along with that, you want to ask about nutrition and water intake. You want to make sure that they are, getting good nutrition and they are getting good water intake as well. And as far also growth, whether they are growing okay, and there's no loss of weight or height, because sometimes malabsorption can lead to failure to thrive. After this, when you want to start an examination, if you to find the cause, you want to do physical examination. Again, you do want to look at the growth of the patient. If they have failure to thrive, you want to make sure there's nothing like that going on. You also want to check the dehydration status, because obviously chronic diarrhea can lead eventually to dehydration. After this, stool exam will probably be your next step. Stool exam, first you're going to look at it grossly. You're going to want to see if it's liquid or if it's very dense. You're going to want to see if there's any blood or mucus that can be seen with your eyes. Other colors really aren't too helpful. Just blood and mucus can help you. Then you're going to want to do a microscopic examination where you're looking for white blood cells and other inflammatory markers. White blood cell, which is a symbol of them. If you see this, that can suggest inflammation. And then there's going to be ova and parasites that you might want to try to see if you can take a look at, such as Giardia and amoeba and Cryptosporidia. You do want to do some other investigations, such as you want to look for occult blood. You're going to want to take a look at the pH, because that can help you differentiate whether it's osmotic or secretory. Reducing agents also help you with that. Electrolytes, and the you want to be able to, and what you want the electrolytes, so you can calculate the osmotic gap. Again, these are all to try and differentiate between osmotic and secretory causes. After this, you kind of go into a second stage after stool exam, where you're looking for other causes, especially if all of these are normal. You want to probably start with the a chloride test to see if you can get find cystic fibrosis. You can also sometimes it can be factitious, so you look for evidence of laxatives. This can be phenolphthalein. You can look for magnesium sulfate and phosphates. These will kind of suggest that maybe it's a fake one. There is another test available, which is the hydrogen breath test, and this checks for carbohydrate malabsorption. And this can generally suggest bacterial overgrowth. You also want to do the anti-tissue transglutaminase for celiac disease, and this is a serum test. And you also want to check the IgA levels to make sure it's not IgA deficiency. And finally, you also want to maybe check some hormones. Before we do that, you want to do endoscopy. So if all of those are normals, you might want to do endoscopy, take a look at the actual gut, and you might want to do biopsy, and then you're going to want to do barium, either a swallow or an enema. And if that comes out normal, then you're probably thinking of maybe tumors, the hormonal tumors such as VIP, gastrin, and secretin. So you probably want to take a look at all of those hormones as well.